Next, we will call Dr. Komal Bakal for presenting on correlation of secondary glaucoma and high-risk histopathology features in retinoblastoma. Over to you, Komal.
Good morning, everyone. I'll be presenting on correlation of secondary glaucoma and high-risk histopathology features in retinoblastoma. So as we all know, the high-risk histopathological features are invasion of the anterior chamber, invasion of the choroid more than 3 millimeters, invasion of post-laminar region of optic nerve or cut end of the optic nerve. There are also certain clinical features which can predict whether a particular eye will have a high-risk feature on histopathology or not. These include symptoms more than 6 months, poor visual acuity at presentation, buphtalmos, ectropia on UVA, orbital cellulitis, glaucoma, and neovascularization of iris. So we already know that glaucoma is a clinical high-risk feature. So why are we doing this study? So here we are trying to stratify the numerical value of raised IOP and its correlation with high-risk histopathological features. And we are trying to understand whether NVI further adds to this risk or not. So we retrospectively analyzed the medical records of 460 retinoblastoma patients who underwent primary enucleation from January 2011 to December 2020. Factors noted were demographic details, presence or absence of secondary glaucoma. Stratification of these patients were done based on the IOP range, and correlation of prevalence of high-risk features on histopathology with the IOP groups was noted, and correlation of presence of NVI with the high-risk features was noted. So out of the 460 eyes, 169 patients had secondary glaucoma with a mean IOP of 32 millimeter of mercury. So when we analyzed the data, we found that only 37% of patients without glaucoma showed high-risk histopathology features, whereas 66% of patients had high-risk features on histopathology who had glaucoma. Coming to the IOP range, in the range between 22 to 30, 55% patients had high-risk features. Range between 31 to 40, 79%, and more than 40, 75% had high-risk features. This shows us that the risk keeps on increasing as the IOP range increases. Also with the NVI, patients with NVI, 69% of them had high-risk features on histopathology. This tells us that NVI doesn't really add to the risk factor here. So a similar study done by Kim et al. In Caucasian population also showed similar results. When we compared the two studies, we noted that the mean IOP in high-risk features positive as well as negative patients in our study was lower. That is, that we can say that in Asian Indians, the eyes are more prone to high-risk features even at a lower IOP as compared to the Caucasian population. This aligns with our previous study where we had compared the overall prevalence of high-risk features. The risk was more in Asian Indian eyes as compared to the Caucasians. So secondary glaucoma is an important independent clinical predictor factor for high-risk histopathology regardless of NVI. Increase in the range of IOP is associated with greater risk, although the risk seems to remain fairly constant as the IOP rises above 40 millimeter of mercury. And high-risk features are noted in Asian Indian eyes at a lower IOP as compared with the Caucasian eyes. Thank you.
Good. It's a nice presentation, and it is very impressive to see that you do such histopathology in all the patients to study the glaucoma. Did it have any significance in the treatment part?
So these were already primarily enucleated eyes, but whenever we go forward, so we are going towards the trend of globe salvage. So it will be important to know whenever a patient has secondary glaucoma, we should be more careful in regards of globe salvage. So that can be helpful.
Very nice study. One question: why do you feel glaucoma is a high risk factor or one of the risk factor for a tumor to have a HRF?
So there are multiple things. There are various mechanisms of this glaucoma. One is direct tumor seeding of the angle, which is of course a high risk feature in itself. Second is neovascular. First is actually neovascularization, then tumor seeding, and third is pupillary block, which means the tumor is already pushing the lens forward and there is pupillary block. So all these things are the reasons I feel why the high risk features are more secondary.
Okay, thank you.
Komal, any possible explanation of why in your group more than 40 millimeter mercury pressure the risk came down compared
Yes.
to the 30 to 40 group? So any
Yes.
possible explanation you've thought through?
We don't really have a explanation for that right now, and that 40 is right now arbitrary. We'll have to have a ROC curve analysis and then get a definitive value above which we can say that above this the risk is higher.
Yeah, true. Okay, thanks, Komal.